Welcome to the Fast Track Cities podcast series, which is brought to you by the International Association of Providers of AIDS Care, or IAPAC. This podcast series chronicles an ongoing worldwide initiative to end urban HIV epidemics by 2030. Each episode features the voices of clinicians, community advocates, policymakers, and people living with HIV from across the Fast Track Cities network, each striving to get to zero new HIV infections, zero AIDS-related deaths, and zero HIV stigma in their cities. And now your host, Susan Berkeley.
Welcome to the fourth episode of the Fast Track Cities podcast series, which is exploring how communities around the world are working to end their local HIV epidemics. I'm your host, Susan Berkeley. The first two episodes describe the almost 4-decade history of the HIV epidemic and gave a sense of why we believe we can end AIDS as a public health threat. The third episode described the Fast Track Cities initiative by answering 3 questions. Why was it created at this pivotal juncture in the fight against AIDS? Why do cities hold the key to ending AIDS as a public health threat? And how are Fast Track Cities implementing efforts to translate global targets into local action? With this episode, we begin a tour of the world, visiting select cities among a worldwide network of more than 270 Fast Track cities. We will explore how cities in different regions are mobilizing to build upon grassroots efforts and implement new strategies to prevent new HIV infections, avoid AIDS-related deaths, and eliminate HIV-related stigma. We start our Global Fast Track Cities tour in the United States. In this podcast episode, we will visit San Francisco and New York City, 2 pioneering cities whose experiences in responding to AIDS have inspired the Fast Track Cities initiative. The first publication to write about the HIV outbreak was a newspaper for New York City's gay community known as the New York Native. As that first article described in May of 1981, patients and their caregivers struggled to find answers as San Francisco and New York City bore the brunt of a rapidly burgeoning epidemic with a stigmatizing name, gay-related cancer. Dr. Jose Zuniga is president and CEO of the International Association of Providers of AIDS Care, or IAPAC. It was created in 1985 to rally medical professionals to meet the growing demand for palliative or end-of-life care for people living with HIV because there were no treatment options available. He recalls those early days.
When I think about New York City and San Francisco, I think about 2 cities that saw almost an entire generation of mostly gay men decimated by disease and subsequent social intolerance that showed absolutely no mercy.
In San Francisco, the Bay Area Reporter, a gay newspaper, added pages to its weekly publication to accommodate scores of AIDS-related death notices. In New York City, the massive influx of AIDS cases threatened the viability of the city's public hospital system. Social service agencies also struggled to care for hundreds of children who had lost their parents to AIDS. Many of these children themselves were living with HIV. Despite these seemingly insurmountable odds, the actions taken by communities of HIV-affected people in San Francisco and New York City in the early days of the HIV epidemic would become a source of inspiration for other cities around the world. Today, these 2 cities have made such tremendous strides in reducing new HIV infections and preventing AIDS-related deaths that concrete plans are now underway to end their local HIV epidemics in our lifetime. Their experiences in transitioning from crisis to achievement illustrate the unique potential of cities to drive progress amidst the most difficult challenges. IAPAC's Dr. Zuniga, who lived and worked in San Francisco during the early 1990s, says the key element in these early HIV epicenters was the leadership exhibited by the most heavily impacted communities to respond to the health crisis.
Commonality in these 2 cities' responses, I think, lies in the passion with which affected communities rallied to demand and then to build the infrastructure necessary to ensure that their fellow citizens, people living with HIV, who died so rapidly in the absence of any treatment, could do so with the dignity that they deserve, a dignity that the virus and societal stigma often denied them.
President Ronald Reagan's administration was criticized by activists for being slow to respond as HIV took hold in the United States and exploded into a public health crisis. Compared to many European countries, the United States devoted relatively few federal resources to the HIV response in the epidemic's early years. The disproportionate impact of HIV, particularly among Black, Latino, gay, and transgender people, amplified the severity of the epidemic within marginalized communities. These communities already lacked access to quality health care due to inequities built into health systems. As the HIV epidemic raged out of control throughout the 1980s and into the 1990s, cities were left to devise appropriate responses on their own, guided by a pressing need to stop the virus's onslaught. We start our Fast Track Cities tour with one of those cities. San Francisco, also known as the City by the Bay, has long been a place of refuge for lesbian, gay, bisexual, and transgender or LGBT people, offering them an opportunity to avoid the stigma, discrimination, and exclusion that they might encounter elsewhere. In 1977, Harvey Milk made history as the first openly gay U.S. elected official when he won a seat on the city's Board of Supervisors. Although his service to the people of San Francisco was tragically cut short when he was murdered by a fellow city supervisor, his legacy of civic activism inspired then and continues to inspire today an army of LGBT advocates. Just as San Francisco was breaking new ground in political representation for LGBT people, HIV was spreading like wildfire within the community. By the late 1970s and early 1980s, doctors in San Francisco began noticing an increase in rare infections among younger gay men and gender nonconforming people than they'd never seen before. AIDS hit San Francisco with the force of an 8.0 earthquake. Dr. Diane Havlier is a professor of medicine who runs the Division of HIV, Infectious Diseases, and Global Medicine at the University of California, San Francisco, or UCSF. She provided care to many of these early patients presenting at her clinic at the San Francisco General Hospital.
In the early days of the epidemic, I was a physician in training in the 1980s and worked at the public hospital in San Francisco General. During those days, there were scores of young men every day admitted to the hospital with end-stage AIDS, severe pneumonias, meningitis, blindness, intractable diarrhea. They were tired, they were scared, they were sick, and understandably, they could not believe this nightmare was happening to them. For those of us who were young physicians at the time, the irony was not lost on us, that we were realizing these dreams to practice medicine at the same time we were caring for these beautiful young men whose dreams had been abruptly shattered. For me, this was a critical moment in my life where I found my lifelong goal to change the course of the epidemic.
It is hard to overstate the epidemic's impact in San Francisco. As Dr. Havlier notes, in a city whose population today numbers less than 900,000 people, nearly 16,000 residents are currently living with HIV.
There are more persons than ever living with HIV in our city, 16,000. Over 90% are MSM and 40% are persons of color. In San Francisco, we have an aging epidemic. Over 50% of persons living with HIV are over 50 years of age. We still, though, have over 200 new HIV infections every year, and a quarter of these are young adults under 30 years of age.
When the epidemic emerged, San Francisco's community leaders created their own HIV service organizations to provide support when municipal resources fell short. Organizations such as the San Francisco AIDS Foundation offered care for thousands of people living with HIV who were being left behind. They also advocated greater attention to the unrelenting health crisis. Ernest Hopkins is Director of Legislative Affairs at the San Francisco AIDS Foundation, where he has led its federal funding, policy, and legislative activities since 1997.
San Francisco AIDS Foundation has this great story. It was one of the first AIDS service organizations to be developed in the nation. And Cleve Jones, one of the founders of the group, which was originally called the Kaposi Sarcoma Foundation, he has a great story about kind of connecting the phone, and from the first moments that the phone was connected, it ringing with someone needing assistance regarding someone who was ill in the city.
The city's medical community also responded. Pioneering HIV clinician Dr. Paul Volberding is co-founder of the UCSF Gladstone Center for AIDS Research.
San Francisco General Hospital is a public safety net hospital, has always served the poor people in the city. This connection, though, to the university was a strong one, so it was a very academic public hospital. And when we started seeing patients, almost immediately our response was to really study this problem, to understand it better, even before we knew it was causing it. The medical response was based on care of poor people, people with frightening conditions, which AIDS was.
Beyond its initial focus on the community of gay men and other men who have sex with men, or MSM, San Francisco's HIV response gradually became inclusive of transgender and gender nonconforming people. Cecilia Chung is a former chair of the San Francisco Human Rights Commission, serving in that capacity from 2008 to 2011 as the first person living openly with HIV. Today, she is Director of Evaluation and Strategic Initiatives at the Transgender Law Center in Oakland, California.
I got involved with HIV work initially because I wanted desperately to find my community. I just came out to my parents at that time of being transgender, and after that, we had a fallout and I didn't have contact with my parents for almost 4 years. And it was during that time that I needed to find a community that I could find emotional and social support.
As HIV-affected communities coalesced, acted in solidarity, and pressured for more resources and services, tensions began to mount as the numbers of new cases increased rapidly to a peak of several thousand per year by 1983. Community leaders and city officials overcame initial disagreements over their response to the HIV outbreak by developing strong working partnerships. Ernest Hopkins of the San Francisco AIDS Foundation describes how these relationships improved public confidence in the city's efforts.
One of the hallmarks of San Francisco is that really seamless relationship that from the inception of the epidemic, really, even in the toughest times, when there were disagreements about health policies, the health department was really run by people who were trusted in the community. And while there were disagreements about the way to go, I think that generally speaking, San Francisco AIDS Foundation and the San Francisco HIV advocacy community has always seen themselves as in partnership to fight the epidemic.
Working together, the LGBT community, the local government, the medical establishment, local universities, and other partners created what became known as the San Francisco model of care. Perhaps the model's most distinctive feature is its emphasis on the broad array of needs experienced by people living with HIV. To provide holistic care and support, San Francisco invested in home care, food services, transportation, daycare, and legal and financial planning services, alongside support for everyday tasks such as grocery shopping and doing laundry. In the mid-1990s, before the advent of effective HIV treatment known as antiretroviral therapy, this model of care primarily focused on helping people living with HIV to improve their quality of life. It also helped people to die with dignity rather than in social isolation, left to die without the compassionate support of loved ones. Nuclear families filled the emotional void instigated by fear of HIV itself and the various phobias, including homophobia and transphobia, that fuel the epidemic. As antiretroviral therapy became more rapidly available, the model of care rapidly adapted to help people living with HIV obtain treatment and to support people living with HIV to adhere to their medication regimens, a need much greater back then than now, given the convenience of HIV treatment available today. The University of California, San Francisco's Dr. Paul Volberding explains.
We suddenly entered the era of transformative therapy, where a previously uniformly fatal disease suddenly was transformed, and people started not only to die more slowly, which had been the case, they actually started to recover. And there are still people alive who were near death, started on the triple therapy, as we called it, in 1996, and they're the lucky ones.
The HIV treatment revolution had a dramatic and immediate impact in San Francisco. In August 1998, for the first time in 17 years, the Bay Area Reporter published no AIDS-related obituaries. That was a stark change for the local gay newspaper that once published more than 30 AIDS-related death notices per week. But before the rainbow came the rain. Early HIV treatments were only offered to individuals who had suffered significant HIV-related damage to their immune systems, which did little to slow AIDS-related deaths. That approach made no sense to San Francisco officials, who noted that people with other life-threatening diseases were offered immediate treatment upon diagnosis. If a person is diagnosed with cancer, they are seldom told to sit tight and wait. Instead, they receive close to immediate treatment for their life-threatening condition. By the early 2000s, clinical studies began to confirm that antiretroviral therapy reduces levels of HIV in a patient's blood to such a degree that these levels are rendered undetectable. Episode 2 of our podcast series recounted a secondary but no less important outcome of antiretroviral therapy, a medical breakthrough that started the beginning of the current treatment as prevention era. HIV treatment can both save the life of a person living with HIV and prevent HIV transmission by that individual. The medicalized term is treatment as prevention is the foundation of today's public health message that undetectable equals untransmittable, or U equals U. Given these medical breakthroughs, San Francisco pioneered the adoption of a new test and treat strategy in 2010. Everyone who tests HIV positive, regardless of their CD4 count or viral load, is immediately offered HIV treatment. This paradigm shift was widely adopted around the world as health authorities actioned the new evidence of antiretroviral therapy for treatment and prevention. Dr. Havlier describes San Francisco's innovative strategy to offer rapid HIV treatment to every person who tested positive for HIV.
We pioneered a program called RAPID, where we link and offer HIV treatment upon HIV diagnosis. Recently, one of our patients who found out that he was newly HIV infected was calling his mom. And what he said to his mom was, "Hi, Mom, I need to tell you I have HIV. But the good news is I am starting therapy today, and I'm going to be living for a long time."
With the support of former San Francisco Mayor Ed Lee, scientists and community activists in the city by the Bay embarked on a more ambitious goal in 2012. They believed it was possible for the city to end its HIV epidemic by getting to zero. This goal is shared by San Francisco and an increasing number of fast-track cities working towards achieving zero new HIV infections and zero AIDS-related deaths, alongside zero HIV-related stigma. Getting to zero is a natural progression from efforts that fast-track cities have been making since 2014 to attain the United Nations 90-90-90 targets. These targets largely focused on making sure that people living with HIV are aware of their status, are on treatment, and achieve viral suppression to achieve zero AIDS-related deaths and U equals U. To get to zero new HIV infections, fast-track cities must also utilize the full menu of available HIV prevention tools, including pre-exposure prophylaxis, or PrEP, which is taken by HIV-negative individuals to reduce their risk of acquiring HIV. Dr. Havlier recalls how getting to zero first began.
It started when we had a meeting at the LGBT Center on Market Street shortly after the International AIDS Conference in 2012. And we had presented interesting data and findings and programs in our city. And at that time, one of our community members in the front row raised his hand and said, "Well, this is all great, but are you all really working together?" The light bulb went off and we realized that we needed to work together more closely. So what we did was that we created the Getting to Zero Consortium and identified our priorities.
Here is Dr. Susan Buckbinder, Director of HIV Research at the San Francisco Department of Public Health.
And you're bringing together disparate members of society to all work towards the common agenda. Our common agenda is really very closely allied with Fast Track Cities and 90-90-90. We want to get to zero HIV infections, zero HIV-associated deaths, and zero HIV stigma and discrimination. And that's what our goal is.
The local consortium formed committees tasked with developing action plans for the 3 pillars of San Francisco's Getting to Zero plan: First, increasing access for PrEP to reduce HIV acquisition by HIV-negative individuals. Second, accelerating rapid HIV treatment initiation as close as possible after a diagnosis. And third, assisting people living with HIV to adhere to and succeed with their HIV treatment to achieve viral suppression. The results have been nothing short of extraordinary. San Francisco has attained the first and third 90 targets, while more work remains to be done to get people living with HIV who know their status onto antiretroviral therapy. Based on 2016 data, San Francisco has reached 94, 79, 94 overall. Ernest Hopkins of the San Francisco AIDS Foundation speaks to the progress his city has made, including in relation to linkage to HIV care.
We have 94% of people living with HIV are aware of their status. 89% of them are linked to care within 90 days. And so that is a very, very favorable set of percentages when you look nationally at people living with HIV.
On the biomedical HIV prevention front, beyond treatment, Dr. Havlier says her city's PrEP rollout efforts are using multiple avenues to reach residents.
As a result of the community efforts, getting to zero in San Francisco, we estimate now about 20,000 individuals are taking PrEP of the approximately estimated 40,000 persons who might benefit from it. Well, how is this done? It is done through many, many different mechanisms that represent the fabric of our committee. For example, we have ambassadors of people who are taking PrEP who talk about PrEP. We have delivery of PrEP at community organizations. We have public health campaigns where one can see advertisements in the bus in public places. We have education opportunities so we can ensure that providers know about PrEP and they can offer PrEP in an effective and respectful way. We have town hall meetings where we talk about how we're doing in PrEP individually and also within the broader Getting to Zero efforts.
Although San Francisco has made great strides in its push to get to zero, like every other city around the world, this city still confronts barriers that jeopardize urban HIV response progress. San Francisco's high cost of living has produced a severe shortage of affordable housing. Many people are often left homeless, and the city's HIV response has struggled to reach them. Dr. Havlier has witnessed the impact of housing instability firsthand.
At our hospital, we recently conducted a survey of about 1,000 of our clients who had come into the clinic over the last couple of months. And what we found was that over a third of these individuals had some form of housing insecurity. We know, and the evidence supports that without stable housing, health is dramatically impacted. Health of HIV-infected individuals is worse, and transmission risk for HIV is higher. For example, people who are couch surfing may need to exchange sex for rent or may not be able to comfortably take PrEP. In our city, overall viral suppression, people living with HIV is about 70%. If we just look at people who are homeless, it's only 35%. This housing disparity also fits into when we consider new infections in San Francisco. Of the new infections in San Francisco, 14% of them are from people who have housing instability or are homeless. We in San Francisco cannot address our goals without addressing supportive housing.
Even in a city as welcoming as San Francisco, social inequality and health inequities present obstacles for some populations of people to access and utilize the HIV services they need. Cecilia Chung of the Transgender Law Center.
I think today we still see some of those situations where transgender people are afraid to get tested. And so I think that that's really where we need to focus more on, because we have the technologies to help people live healthier and longer. And it's a matter of helping everybody to understand where their baseline is and also provide the necessary treatment to engage them in care and also to provide them with a sense of future.
Over time, San Francisco's HIV epidemic has also become more concentrated among racial and ethnic minorities. Ernest Hopkins of the San Francisco AIDS Foundation reflects on the city's African American community.
African Americans make up a relatively small percentage of the population in San Francisco, but then see a disproportionate percentage of the HIV epidemic being African American. And, it's just a historical reality that African Americans in the city are usually living in communities where the poverty level is higher, the education level is lower, median income is lower, employment status is lower, and rates of health insurance are also lower, and rates of homelessness are higher.
These challenges are starkly apparent across the San Francisco Bay, in the city of Oakland, another fast-track city, whose HIV epidemic bears mentioning in context with San Francisco's epidemic. Dr. Marcia Martin lives in Oakland and has worked in the HIV field since the 1980s. She currently serves as the coordinator of the Global Network of Black People Working with HIV and spearheads that city's fast-track cities advocacy.
San Francisco's epidemic is largely a gay men's epidemic. Oakland's epidemic is largely one of gay men, women, and children. And they are gay men, women, and children of Black and Latino and Asian ethnicities. The reality is the resources are different. The gay community came together in San Francisco in partnership with the city and in partnership with the county to build effective programs and responses. Oakland didn't have that gay community to organize and come together, didn't have that gay section of town.
Under the banner of the Fast Track Cities initiative, San Francisco and Oakland are working to overcome their challenges and put themselves on the track to end their local epidemics. For example, San Francisco's Getting to Zero Consortium is addressing the city's lack of affordable housing by calling on municipal leaders to provide subsidies to people at risk of losing their housing. These two communities are also working together to see how the lessons from San Francisco's HIV response can be applied in Oakland. Here again is Dr. Martin.
Oakland doesn't quite have the infrastructure that San Francisco has to respond. And if we didn't have a bay between us, we would probably be sharing those resources more readily. So we're beginning to look at how can we take a look at the expertise that has been developed in San Francisco and some expertise in Oakland, bring together all the key players and look for how we might enhance a regional response.
From the west coast of the United States, we now travel to its east coast and turn our focus to New York City. Known as the Big Apple, New York City is the world's cultural and financial capital. The headquarters of the United Nations is located here, and almost any language of the world can be heard on its streets. And whereas San Francisco is home to less than 1 million people, approximately 8.5 million people live in New York City. Nearly 4 in 10 New York residents were born outside the United States. One section of New York City alone, Queens, can boast that more than 200 languages are spoken in the homes of its residents. Peter Staley is an openly HIV-positive New Yorker who has been an outspoken national activist on behalf of people living with HIV.
It's one of the great melting pots of the world, and it's a very proud sanctuary city, a term used in American politics these days for one of the blue areas of the country. They're very proud of the fact that immigrants are what make us great. It's a city of immigrants. It always has been. It always will be. By and large, most of the people live there believe in that, believe that that's one of our greatest strengths. That's why I love it more than anything else, is its diversity.
The Bronx is not only one of the most HIV-impacted areas in New York City, its residents face some of the highest HIV rates in the world. Dr. Donna Futterman, who practices HIV medicine at the Bronx Montefiore Hospital, is a leading expert on HIV and its impact on young people.
New York City is an incredibly diverse place, and what's made New York City powerful, wonderful, exciting is the fact that we have welcomed people from the entire planet into creating this culture that's New York City. We are constantly refreshed by immigrants from new places. Recently, the Bronx has become a hub for immigrants from West Africa. Brooklyn is a hub for immigrants from the Caribbean, Indian, Pakistanis, people from all over Latin America, Europe. I think, New York's richness, diversity, history, culture, all of that is based by the fact that we're a world city and have managed to have minimal stress between the races and places and maximum diversity and delicious food and clothing and music and all of that because we welcome people from the entire world.
Today, more than 120,000 people in New York City are living with HIV. During the epidemic's early years, gay men and transgender people bore the brunt of new HIV infections in much the same way as San Francisco. However, by the late 1980s, injection drug use became the primary means of HIV transmission in the city. In 1981, the New York Times alerted the community, and due to its global reach, the world, about this new public health emergency. Although he now lives in San Francisco and works at the San Francisco AIDS Foundation, Ernest Hopkins was a young college student living in New York City when news of the HIV epidemic first broke.
I was a junior in college in New York City in 1981. Read the New York Times like everybody else and was roommates with a guy who had a membership at a very kind of popular club in the East Village called the Saint. And I used to go there, and it was kind of one of the places that all the beautiful people hung out. And slowly but surely, we began to start hearing about people who were getting sick and kind of disappearing, or getting sick and going to the hospital and then kind of being off the scene. And that happened very quickly in 1981. And, everyone was just freaking out.
Unlike San Francisco, where gay men have accounted for about 90% of cases, New York's epidemic has always had a wider impact. Today, men who have sex with men account for 54% of new HIV diagnoses in New York City, and for about 4 in 10 of all people living with HIV. Moreover, non-white communities account for 80% of people living with HIV in the city, and roughly 1 in every 3 new HIV infections come from neighborhoods where more than 30% of the residents are living in poverty. As in San Francisco, the communities that felt the greatest impact of HIV were the first to respond to this new health crisis. Kelsey Louie, the CEO of Gay Men's Health Crisis, or GMHC, reflects on those early days by recalling the formation of his AIDS service organization by legendary writer and AIDS activist Larry Kramer.
Gay Men's Health Crisis is the world's first AIDS service organization. Started in 1981 when 6 gay men and their friends gathered in Larry Kramer's living room in Greenwich Village to talk about what would then become known as AIDS. We officially launched in 1982 with one of our first services being the AIDS Hotline, a program that is still core to what we do today. In the early 80s, much of the work of GMHC was about providing proper and good information to the community, and we still do that today.
In the early years of the epidemic, advocates from New York City's LGBT community often criticized municipal officials for failing to take the epidemic's threat seriously. Kelsey Louie of Gay Men's Health Crisis says activists played a critical role in galvanizing action by officials at both the city and state levels.
Throughout the AIDS epidemic, in many ways, our community pushed for progress and often outpaced city and state government. In the earliest years of the epidemic, it was organizations like GMHC and ACT UP, which was founded by some of GMHC's leaders, that helped catalyze a robust response to the epidemic. We often had to depend on our own strengths to help get the care and response we and our friends with HIV/AIDS needed.
As frustration grew among people living with HIV and their advocates, Larry Kramer, one of the founders of Gay Men's Health Crisis, called an urgent community meeting at New York City's Lesbian and Gay Community Services Center. ACT UP, the AIDS Coalition to Unleash Power, was born out of the frustration felt by so many infected and affected people. Peter Staley, who was an early ACT UP member, describes ACT UP's rapid growth, both locally and as a global movement.
We became the movement of our day, and we were something that the country had never seen before. They had never seen hundreds, if not thousands, of homosexuals demonstrating in the street on a national level, determined and angry and desperate. They had never seen a patient group of a life-threatening illness rise up and demand to be heard. And I think that early uprising and that burst onto the national scene and that changing of the national conversation, I think that was our greatest success. Polls showed very quickly that the country was kind of felt guilty about the lack of national response. And they wanted the federal government to spend money on AIDS research. And the federal dollars started to flow. The NIH AIDS research budget tripled during the first 3 years of ACT UP, reaching over $1 billion a year.
Charles King is the executive director of an HIV service organization called Housing Works, an organization that has served upwards of 30,000 homeless and low-income New Yorkers. He recalls the early days of ACT UP.
There was, my whole community became ACT UP, and, it was a time of intense fear, a time of intense anger and rage, and yet a time of enormous creativity and love and people coming together because we all felt like we were fighting for our lives, and if we didn't take up the fight, no one else was going to.
At the same time, the epidemic was prompting unprecedented community activism in the gay community. Rates of HIV infection grew alarmingly fast among the city's African American residents. Tracy Gardner, Vice President of Policy Advocacy at the Legal Action Center in New York City, has been a leader in the HIV response for nearly 3 decades.
The experience of white gay men in New York and the experience of Black communities where there was a lot of intersection with criminal justice and with substance use and with the stigma and people unwilling to talk about anything related to sex and the virulent homophobia, the denial of the Black church, just a whole different landscape of issues that played out that was very different and not something you would be able to discern from some of the more popular tellings of what was happening then in the late 80s and early 90s.
As HIV devastated low-income communities, New York City began to use its HIV resources to address underlying structural sources of vulnerability. The HIV/AIDS Services Administration, also known as HACA, directly focused its attention on addressing the social determinants of health that many New Yorkers living with HIV face daily. Here again is Tracy Gardner.
You cannot just treat their HIV and not address the fact that they didn't have homes, not address the fact that they weren't able to eat regularly, not address the fact that they had children who some of the children were HIV positive and some weren't. I think this is where the AIDS community, regardless of race, was able to come together and force public policy and funding to address the structural issues.
New York City's sizable Latino community faced many of the same challenges. Guillermo Chacon is president of the Latino Commission on AIDS. He notes that Latinos who are living with HIV or who have a higher risk of acquiring HIV often struggle to overcome additional barriers that can prevent them from gaining full access to HIV-related services.
This Latino community represents 29% of the New York City population and represent 33% of the epidemic. The most affected segment of the community is definitely gay bi men, especially young. And very, very particular detail is the dynamics between U.S.-born and foreign-born Latinos and Latinas. Also, we have been identified that trans individuals, also from a Hispanic Latino ethnic background, are heavily affected, and also cisgender Latinas are also facing a serious impact of HIV. The main issues and challenges are still the difficulties to navigate, even in New York City, that is have several opportunities and sources of services, how people are able to navigate the services, and especially support services such as housing, such as sustainable healthcare. And the other challenge, even though we face here, is the issues related to stigma and discrimination. A lot of people don't have the patience to navigate those individuals that are still struggling to understand English perfectly or having some immigration issues in terms of status.
By the mid-1990s, New York City began to witness real progress as new treatments offered a lifetime to people living with HIV who were previously guaranteed a death sentence. Here again is Charles King of Housing Works.
At the peak in New York, we had over 15,000 new infections a year. We thought we'd made major strides. When around 2006, we got it down to 5,000 new infections a year. We're now down with new incidence number that is probably around 2,300 or so.
The human impact of the HIV treatment breakthrough with antiretroviral therapy was as profound in New York City as it was in San Francisco. Tracy Gardner of the Legal Action Center also remembers the mid-1990s as a key turning point.
So 96 was a huge year for me in terms of having my first baby, but also it's like the Lazarus year. Like when we talk, those of us who we're very much still connected, and that demarcation line of 95 to 96 where people were dying all the time to when people, quote unquote, stopped dying.
With the medical option to stop HIV disease progression among people living with HIV who could access treatment, New York City's future in addressing HIV next hinged on forging a much stronger alliance between the city and the communities most affected by HIV. Kelsey Louie of Gay Men's Health Crisis reflects on today's HIV response.
Today, however, things are different. Community-based organizations experience a very good relationship with our local government. In fact, in New York City, we have a very robust and productive relationship with our city and state departments of health. In fact, both New York City and New York State, our departments of health are seen as leaders and pioneers.
Guillermo Chacon of the Latino Commission on AIDS reiterates the point, stating that the city health department's strong relationship with his community has been vital.
The relationship between the Latino communities and the city health department is fundamental, because the health department is the vehicle, the expression of city government in charge to maintain in New York as a healthy city. We have been very blessed to have a very, very strong health commissioners.
As in San Francisco, community activists helped jumpstart discussions about ending AIDS in New York City. With encouragement from AIDS activists, New York State Governor Andrew Cuomo called for the development of a plan to end AIDS in his state by 2020. For more than 2 decades, Dr. Bruce Agins was the senior medical officer at the New York State AIDS Institute. He is now a professor at the University of California at San Francisco's Institute for Global Health Science.
The New York State response to AIDS is a long-standing response, but it was heightened several years ago when Governor Cuomo released the mandate to end the epidemic by 2020. And that then involved the convening of a large stakeholder group from throughout New York State, which included New York City, to develop what was called and is called the blueprint to end the epidemic. And those community meetings involved a wide range of stakeholders, providers, community providers, people living with HIV, from all of the different affected groups. And they met in different subcommittees to develop strategic recommendations that became part of the blueprint. And that blueprint was then approved by the governor after a whirlwind 3-month process of development and execution and public comment, I must say. And it was signed off by the governor and then officially launched.
The New York State Blueprint to End AIDS has 3 pillars. First, identify people living with HIV who remain undiagnosed and link them to care. Second, retain people living with HIV in continuous care and maximize viral suppression. And third, facilitate access to PrEP, particularly among communities that are at higher risk of acquiring HIV. New York State took immediate steps to implement the blueprint, including creating a fund to assist PrEP users to pay for the cost of drugs or laboratory expenses. But most of the activities aimed at ending AIDS in New York State have occurred in New York City, which accounts for a majority of people living with HIV in the state. These activities would not have been possible without the support of New York City Mayor Bill de Blasio and other local political and public health leaders. Dr. Dimitri Daskalakis is the Deputy Commissioner for the Division of Disease Control at the New York City Department of Health and Mental Hygiene. He explains the rationale behind New York City's effort to end this fast-track city's epidemic.
When we started our work to end the epidemic, it really was sort of three main stakeholders that we focused on. So scientists, folks who knew the medical and scientific story of the technology that could be used to drive the HIV epidemic down despite the absence of a vaccine. Our second stakeholders were community. And by community, I take that to be something very broad. So people who are really activists, as well as community-based organizations, providers of service, and providers of medical and other care. And then finally, our other stakeholders are a broad base of politicians. So people who work in city hall, city council, state government. So really, we have a really broad-based group of people that came together to generate the enthusiasm and really the programming that we're using to accomplish our fast track city goals, as well as our ending the epidemic goals in the state, which are very well aligned.
New HIV infections in New York City began to decline around the year 2000, and the number of AIDS-related deaths today is about 1/5 the number at the local epidemic's peak in 1995. Recent reports suggest that New York City continues to make progress in its effort to accelerate the decline of its epidemic. The number of new HIV diagnoses recorded in New York City in 2016 was the lowest since the city began collecting these data in 2001. The city is also close to attaining the Fast Track Cities Initiative's 90-90-90 targets. As of 2017, 93% of people living with HIV in New York know their status, of whom 86% are on antiretroviral therapy. And among people living with HIV who are on antiretroviral therapy, 93% have become virally suppressed. In other words, New York City is already at 93, 86, 93 with respect to the Fast Track Cities targets based on 2017 data. New York City's work to end its HIV epidemic has leveraged public health innovation. For example, the city took steps to reimagine and rebrand its existing standalone STD clinics, which historically screened and treated sexually transmitted diseases. Dr. Daskalakis from the Department of Health and Mental Hygiene describes how these repurposed clinics created space to innovate new sexual health strategies in response to the community's needs.
And so they were all renamed sexual health clinics, and their mission followed their name. When the mission changed, we also built within it what I think, again, is one of the most interesting ways to implement HIV prevention and treatment. So we launched 3 programs simultaneously. By simultaneously, I mean painfully over a year, since it took so much effort to get them moving. But ultimately, we launched post-exposure prophylaxis 28, which means that we gave people full courses of prevention medicines, not just starter packs and referrals. So it wasn't here's 3 days and see you later. It was here's 28 days, go. We thought that was going to go well, but we didn't think it was going to be threefold as popular as we had modeled. So we in the time that we expected to do 500 post-exposure prophylaxis have done almost 1,500.
Building on the repurposing of the STD clinics to amplify the promotion of sexual health, New York City also launched the Jumpstart initiative to offer the same-day initiation of antiretroviral therapy for people who test positive for HIV at sexual health clinics. Dr. Daskalakis says this proactive approach has already yielded substantial results.
Jumpstart is our rapid initiation of antiretroviral program at the time of diagnosis. That has been amazing. The result has been that about 10% of new diagnoses in New York City that have been found at our sexual health clinics have been started on antiretrovirals on the day of their diagnosis, with resounding level of connection to care. And though I can't give you the exact number, really significant and rapid decreases in viral load to viral suppression in a very short amount of time. Really amazing.
The city has also made a major financial investment in expanding the availability of PrEP for people who are at a higher risk of acquiring HIV. Charles King of Housing Works says the increased availability of PrEP is playing a vital role in reducing the number of new HIV infections in New York City.
I think PrEP access has been the number one driver in the 2016 data in driving down new infections among men who have sex with men. But there's also been both a statewide and a separate New York City media campaign that has done a lot of education around PrEP, and a lot of that media campaign has targeted especially men of color who are gay and bisexual.
In line with a cross-cutting priority in New York State's Blueprint for Ending AIDS, the city is prioritizing assistance to prevent people living with HIV from becoming homeless. Charles King explains.
Thanks both to the effort of Mayor Bill de Blasio and Governor Cuomo, New York City became the first jurisdiction in the world that guarantees supportive housing or enhanced rental assistance to every single low-income person living with HIV. And I think that is ultimately going to prove to be what propels New York City ahead of other jurisdictions in terms of innovations to really get to an end of the epidemic.
Altogether, Charles King says the gains that New York City has made against HIV are inspiring. They are particularly hard to fathom for people who have been in the trenches of the AIDS fight since the epidemic's early days.
I'm happy to say we're winning the war.
Like San Francisco, New York City still faces challenges in its quest to end the public health threat posed by AIDS. Much work remains to be done to address racial and ethnic disparities in access to HIV prevention and treatment services. Persistent stigma associated with HIV jeopardizes efforts to deliver quality services for all people living with and affected by HIV. And sometimes, stigma is due to factors beyond HIV and more to do with race, gender identity, substance use, and/or mental health. Moreover, adequate funding for the full continuum of HIV prevention and care services also remains a key concern as national health budgets contract, which requires vigilant advocacy of the nature New York City's HIV community is experienced in and will continue advancing as it strives to end its HIV epidemic. So, what does the future of the urban HIV response hold? Not to be coy, but only the future will tell. However, the two fast-track cities we visited during this podcast episode are clearly on the right track. Today, San Francisco and New York City are within sight of ending their local HIV epidemics, and their experiences are influencing local practice in the United States and around the world. In subsequent podcast episodes, we will hear how these experiences are inspiring other cities, but also how geographically diverse cities are learning from each other in common cause against HIV and AIDS. Stay tuned for our next podcast episode as we turn our attention to fast-track cities in the southern United States. We will explore how cities in this high HIV burden region are strengthening their local HIV responses in the face of rampant racism, heterosexism, and socioeconomic inequality. Please join us.
Post-exposure prophylaxis, otherwise known as PEP, is a course of antiretroviral drugs that can reduce the risk of infection after events with high risk of exposure to HIV, including unprotected anal or vaginal sex, needle stick injuries, or sharing needles. PEP should be used only in emergency situations and must be started within 72 hours after a recent possible exposure to HIV. If you find yourself in such a situation in the future, seek medical attention within 72 hours of exposure and ask your clinician to prescribe PEP for you. You may also visit www.cdc.gov for more information about PEP.